a single or double dose regimen, when you're going to take that for a duration of at least around 8 weeks of therapy, even after that, if the symptoms is not going to get improved, or if the endoscopic severity, if it is not going to respond properly, then we are going to consider the patient for refractory GERD. Your list of conditions and now mentioned to diagnose the etiological factors for refractory esophagitis. Among them, one common indication, we should not forget your eosinophilic esophagitis, and apart from your drug-induced esophagitis, that's called pill esophagitis. And most of the time, whether the patient adhering to the drug properly or not, whether the patient strictly following the diet regimen or not, all those things is there to look into the consideration, like echalasia, any motility disorder. If the patient is having, so you need to recognize always gastroenterology, even though the management process tends to be very complicated. Clinically, recognizing the patient looks to be very, very simple, because the symptomatology analysis for your gastroenterology based upon very few things. So alarming pointers, the red flags you need to identify if any patient is going to land up. The common red flag, if the patient tends to have evidence of dysphagia, that's very important. You should be very cautious to that kind of patient. Apart from that, if the patient is going to land up with any evidence of bleed, either in the form of upper GI or lower GI, so you need to be cautious. And if you are going to identify any mass, if the patient is having evidence of weight loss, which means significant weight loss. What do you mean by significant weight loss? In case if the weight loss tends to be more than 10% of your body weight in a span of time. So these are all the basic alarming pointers we are not supposed to identify. And unidentified focus of your anemia, you cannot able to. So things looks to be very simple to recognize the presentation. So you need to cautious to identify whether the patient is having evidence of functional GERD, or if the GERD patient tends to have evidence of any coexisting worsening of complications like malignant changeovers, a bad changeover in which your esophagus is, the squamous epithelium, if it is going to take on with your columnar epithelium of the stomach, that's one what condition is called as Barrett's, in which the patient tends to high risk to progress for adenosine as they progress. So these are all the basic things you should not forget when you're going to address a patient with gastroesophageal reflux. That's why we like to point out proper assessment, proper history taking, proper counseling, diet, and managing a patient with serial follow-up is important. With all these pointers, if you're going to diagnose a refractory GERD, you are going to start the patient on a molecular support. So you need to see whether the patient is responding to the treatment, or whether the patient is having partial response, or whether the patient is not having any response. As I've already discussed with you, there is basic guidelines on non-erosive, your erosive, your Barrett's, and if you see, the most important thing is always PPI, you need to be very cautious when you're going to use, because there are newer enzymes being considering in the molecule. See, GERD, starting from your alginate preparation. Alginates, even if your aluminum compounds, even if your magnesium compounds, we are going to use, that's right from the initial phase of molecule in which it will be a rapid onset of action. So that's a basic thing, starting from your alginates, starting from your H2 blockers, one of the fantastic molecules for most of the conditions you can be able to use. But the problem is tachyphylaxis. What do you mean by tachyphylaxis? Once you're going to use that kind of a molecule for a duration of time, most of the patient will be having a tolerance. The patient may not have a significant effect. And moreover, if you're going to do an endoscopy, recently I've seen a young boy who had pill esophagitis being treated by a consultant outside who gave naproxen for evidence of some rheumatologic focus. He took naproxen for more than 3 times a day for more than a duration of 1 month. He presented to me the background of dysphagia. He is just 16 years old. I've done an endoscopy to him. It shows evidence of a esophageal severe traumatized mucosa that was in the grade of almost grade D esophagitis as per the classification, what is called as Los Angeles. So if you're going to identify that kind of problem, so it's almost mimicking a malignant changeover. But even though clinically, considering the age of presentation, considering the events, how is it progressing, so even though we are checking a biopsy safely, it doesn't show any evidence of malignant changeover. It's proven to be a esophagitis, to whom we are subject the patient with a PCAB. Our experience tends to prove that it is almost equal in potency to compare with your proton pump inhibitors with your potassium competitive acid blockers. So what I would like to point out, so always you need to choose the patient to whom you're going to try, what are the various molecules you're going to address. That's very, very important. And PPI, you need to be very cautious because huge list of adverse events are there to get report with your PPI when you're going to manage a patient with GERD. Diagnosing a patient with GERD is difficult and cumbersome once you're planning for any surgical intervention or laparoscopic intervention, or whether the patient is going for any endoscopic intervention. So you need to whom you're going to choose for impedance assessment, your Bravo capsule along with your 24-hour pH metry. All the there's a scoring system, what is called as a DMIS scoring system, in which you're going to identify the reflexive pathology, what is going to happen in your GERD. So why I would like to say this, so diagnosing a patient with GERD is important. Once you're going to diagnose the management, if you're going to start on PPI, whether you're going to use once daily regimen or twice daily regimen, high dose regimen, or what are the things you're going to use, the most problematic thing is PPI, the main mechanism of action is your hydrogen potassium ATPase is going to get blocked off in your parietal cells in the stomach. So it will take minimum duration of 3 to 5 days to get act to inhibit most of the acid pump. But the acid pumps will get released within a span of 24 hours of time. So that's why even if you're going to prescribe your PPI to the patient, so what's going to happen? Most of the time the patient will not respond to the initial phase of regimen unless you are going to give at least 3 to 5 days of duration for the patient to get addressed. So this is what is very important. And moreover, it is going to block irreversibly your hydrogen potassium ATPase pump. That's one important, and it requires an acidic medium to act. That's one complexity to address. Always we need to maintain a pH that should be in the acidic medium phase to maintain that kind of thing. And your list of adverse events being reported. The problem with your PPI when you're going to tackle this, whether this adverse event is because of your PPI or because of some other molecules, we are not very sure. And there are no much of data to prove that. Even though if the patient is going to land up with this kind of presentation, it is very difficult to recognize that problem is mainly because of your PPI. For example, starting from your findings like in the background of acute kidney injury with interstitial nephritis. There are many papers to document because of this PPI, but how far we are coming across in a routine clinical practice is questionable issue. Apart from that, when you're going to use your PPI, there is a cardiac event, what is called a major acute coronary event. See, why am I saying all those things? See, whenever you're going to start a molecule to your patient, you need to be cautious because the complications, what are the comorbidities the patient is having, you need to assess, and based upon that, you need to choose the best molecule. Because PPI, most of the time, we as a gastroenterologist, as a physician, we will not be using alone. Sometimes we'll be combining with your prokinetic. You may use your domperidone, you may use your levosulfide, zincopride, so many other molecules for your prokinetic, etopride. So you need to be cautious to whom you're going to choose this molecule. What is the presentation, whether it is only GERD, whether it's any severe refluxate. That's what is assessing the patient as a whole to tackle this kind of clinical presentation. And you have a list of adverse events starting from your hypochlorhydria, magnesium depletion, sodium depletion, along with, for example, we are seeing in primary essential practices in the peripheries, most of the time the patient will be prescribing 20 milligrams of omeprazole BD dosage for a duration of years. If the patient is consuming BD dosage for a duration of years, so what is going to happen? Most of the time the patient will be landing with evidence of your funding gland changes. So if you're going to see, you may identify a small polypoidal lesion in your GI tract. Once, if you're going to identify such common findings in your GI tract, I came across multiple patients with similar findings, so it's very easy to recognize. So always do proceed this kind of patient for your PPI at any point, because these GI polyps, there are some reports still proven that it tends to be in the range of adenocarcinoma of GI, of stomach to get progress. So you need to choose the patient, that's very important. Long duration of therapy, be very cautious to use, and use list of adverse events. And for example, your cardiac events. For example, if you're going to use omeprazole or pantoprazole or your ramiprazole or lansoprazole, esomeprazole, what are the molecules you're going to use? Cardiac events has to be strongly addressed because there are two major interactions in whenever you're going to use your PPI. One is because of your CYP2C19 pathway, and the another one is because of your CYP3A4 pathway. Your CYP2C19 is a predominant mode of action for your most of the cardiac molecules. For example, your antiplatelets, thrombolytics, all those things. COP2C19 powders will be in target. So that's why whenever you're going to use a PPI, you need to cautious to choose the best of PPI. For example, rabiprazole, the infection will be very less with your COP2C19. That's why most of the cardiologists they will be preferring rabiprazole is the primary line. Apart from so many other molecules like semiprozole is the next in armamentarium, your omeprazole is on its down track, and your lansoprazole is still higher in the field. So this is how we need to determine what are the various things, and this is how we need to categorize the patient to whom you are going to use. Starting from egg to food, there are huge list of adverse events being here to report, and my interest is not to talk on that mainly, but you should remember that. So the basic indication, see this slide is all mainly focusing on PPI when you are going to use. So always we need to target our intragastric pH as to maintain more than 4. Is it happening or not? That is one question to get addressed. How long it will take to get at? That's second question. Apart from that, even though if your intragastric pH, if it tends to be augmented, what is about your nocturnal acid breakthrough? You have been seeing most of the patient, even though they're going to get PPI in the daytime, they will get a frequent awakenings which gets happen in the nocturnal events. So whether your PPI will act on that, around 10 to 20% your nocturnal events will get suppressed by a PPI. That's one problematic area to get at, because nocturnal symptoms make the patient to go down, psychological depression, other events tends to get progress. So nocturnal events you need to get prevented. So NABs, that's one very important thing to get addressed, your nocturnal acid breakthrough. That is why they have been recommending H2 blockers. H2 blockers very fantastic whenever you are going to use your PPI, and whenever you are going to use your H2 blocker, PPI in morning and H2 blocker in the night time before food, will be having a potential benefit. That will be if you are going to give a high dose H2 blocker. For example, the best of molecule will be a ranitidine. If you are going to use at a rate of around 300 milligrams, already cimetidine will be withdrawn in the market because of your other effects apart from the new molecules like lafitidine and other things in the field to consider. But H2 blockers to prevent your nocturnal acid breakthrough is one of the strong potential indicator to consider when you are going to tackle a patient with GERD along with your PPA. But the problem with your H2 blocker, for example, if the patient is having erosive esophagitis, if the gastroenterologist is easy to recognize, put an endoscopy, identify the finding, multiple mucosal injury, there will be linear trauma which is going to get happen because of your continuous acid eructation which is going to get happen. So how are you going to recognize that? So this kind of scenario is always you need to use your PPI because the response rate will be around 60 to 80%. But in your H2 blocker, the response rate only will be in the range of 40 to 50%. And moreover, the complete response will not yet happen. That is why so many newer add-on therapies being there. For example, your revamipide, your sucralfate, all those things may be add-on to your molecule with your PPI. But even though vanaprazone in that kind of condition, for example, to tackle that kind of events, your potassium competitive acid blocker will be having potential response even you are going to tackle your erosive esophagitis. And the PPI, as already discussed, why the mechanisms of failure which has been mentioned in this flow chart, you need to see that non-compliance, improper dosing, rapid metabolism. This is all the basic things. And very importantly, the major indications for your PPI usage will be your erosive esophagitis, reflux esophagitis. Apart from that, if you are going to have a non-erosive reflux disease, as already discussed, your 60 to 80%. And very importantly, one characteristic picture will be your gastric ulcer, your duodenal as well as your gastric ulcer, your peptic ulcer. And how are you going to tackle a patient for H. pylori eradication, which is one of the most important area to get addressed, because H. pylori, if you're going to initiate the patient with either amoxicillin or metronidazole or clarithromycin based regimen along with your PPI, most of the patient will have worsening of your GI symptoms. Some patient will have persistent diarrhea, some patient will have worsening of fever, because when you are going to put a high dose of molecule for a duration of at least 10 to 14 days to tackle your H. pylori, there are no single probable entity to diagnose H. pylori properly. Even if you are going to do a rapid urease test, or if you are going to do a urine culture or blood analysis, then you are not going to identify. One thing, your endoscopic assessment and proper histological assessment will yield your H. pylori properly. That too, the sensitivity rate will be around the range of around 80 to 90% for your endoscopic assessment severity for your H. pylori. So that is why H. pylori, it tends to be very difficult. And when you are going to tackle your H. pylori with a molecule, if you are going to put, for example, your triple drug regimen for clarithromycin along with your amoxicillin, along with your PPIs, if you are going to start, the response rate will be only in the range of around 60 to 80%. So some patient may have a refractory and the patient may have H. pylori positive again, and to that kind of patients you need to subject with coordinable therapy with your glismet, your subsalicylate or subcitrate at a dose of around 120 milligrams BD. So this is what we can consider for a patient with this kind of eradication therapy. And this new add-on with your vonoprazole. So vonoprazole, to talk on that molecule briefly is, so this is what the basic things. And always you should not forget about, not only about acidic reflux. There are some reflexes which is most of the time will be happening even in your alkaline pathology, weak acidic reflex or alkaline reflex. These all things will be very difficult to control with your PPIs alone. That's what the most important thing you should not forget. And as already discussed, your metabolic pathways and all those things being recorded in this flow chart. And nocturnal acid breakthrough, residual acid reflux, functional Heartburn reflex hypersensitivity as I discussed. This is what the basic entirety. And various differential diagnoses for your motility disorder, your heartburn, your esophageal discuss, your infections. So how the erosive esophagitis is not only mainly based upon your eosinophilic. So eosinophilic esophagitis, for example, if you are going to do endoscopy, you can able to identify a prominent circle of furrows, and you are going to take a biopsy, you can able to prove that eosinophilic counts if it is tends to be more than 15 per type of field in your assessment. So that's easy to recognize. But your infectious esophagitis will still very complexity. For example, your viral, your HSV, your CMV, your fungal events, apart from that, and immunocompromised scenarios. So those kind of patients will be having your infectious esophagitis will be very complex to tackle, because this kind of patients, when you are going to put a PPI, there might be evidence of worsening of infections, because PPI, you should not forget, intensive care setting. If the patient is having intensive care, if the patient is having evidence of septicemia, whenever you are going to use your PPI, you need to be very cautious. So, because there are multiple events, for example, start from your liver. The common picture will be any inflammatory cascade, for example, your acute liver failure. In case, in that kind of background, if you are going, most of the hospitalized patients, irrationally they will start on IV proton pump inhibitor, IV pantoprazole. So, is it recommended? Is it so? No, you are not supposed to do that, because it is going to act on two major pathways. One is PAMP and DAMP. What is a PAMP and DAMP? It is nothing but your pathogen pattern, molecular associated pattern, and your damage associated pattern. These two things, if it is going to get hacked on, there might be evidence for the patient to have worsening of symptoms. So you should not use your PPI, rather than you can go for H2 blockers to that kind of patient. Apart from, if the patient is having evidence of, for example, if the patient is having GERD, and some patient will be having coexisting inflammatory bowel disease in your lower GI tract. For example, if you are treating a patient with severe ulcerative colitis, the patient may have risk of Clostridium difficile infection. That's nothing but your antibiotic associated colitis. You have been seeing most of the patients who are being given irrational amoxicillin just like that for many of the patients, starting from your physicians, all those persons using. That's a common molecule which predisposes starting from your GI diarrhea, from your major liver toxicity. So you should not forget that, because whenever you are going to start on this kind of molecule itself, that will be having a worsening of events to get problems. So these are all the areas to address. A motility disorder, very difficult to diagnose, very difficult to recognize. Achalasia, simple manometry, endoscopy, very prominently dilated proximal esophagus, distal esophagus will be more narrowed, and you can able to always identify dysphagia to liquids, very characteristic. You can able to recognize always the fluids chases will be there in your esophageal tract. You can able to see, and nowadays the endoscopy has gone beyond the reach in which the POEM and other interventions are there to take on comfortably without any major surgical intervention to tackle this kind of presentation. And always functional issues is always a complicated one to recognize most of the time, to tackle that kind of presentation is also very difficult. And this is all the various modalities to diagnose, as already discussed, your pH metry and all those things. Therapeutic approach, various molecules are there, starting from your PPI, H2 blockers, PCABs, and very importantly, never forget, all these molecules alone will not tackle your presentation. So some patient may require SANS control, because that is the area of trigger which will predispose. So some patient may require antidepressants like your TCA as well as SSRI. Some patient may require counseling. Some patient may require baclofen, in which the patient, if the patient has persistent reflux and other conditions, along with the permanent hiccups and other things. So in order to improve your TNSCR, relaxation and all those things, you can use your baclofen 10 milligrams GDS therapy at that point of junction. So these are all the basic molecules are there to address, but the key molecule what you are going to talk on is your PCABs. That's very, very important. And general measures, as already told you, meals, tobacco, chocolates and all those things, pH monitoring is important. And strategy, single dose regimen, double dose regimen of your PPI, and high dose regimen. See, what is the double dose regimen? If you see, the main thing is, if you are going to start on your high dose PPI, the initial phase will be in 1 to 2 hours, for example. The second phase of release of your PPI will be in range of around 10 to 12 hours of therapy. So this is what it will be having a potential significant acid separation. But the problem with this high dose PPI, there are many patients, many case reports are there, that kind of patients will have evidence of adverse events to get problems. So rather than going for high dose PPIs to prevent that, that's why the leave entirety of your potassium, your PCAM as there to take on in the field to tackle this kind of presentation. And switching to another PPI. If the PPI is not responding, and if you want to switch on to another PPI, these are the papers to validate your points, but you cannot say there is one molecule will be superior to another molecule in your routine clinical practice. And as I already told you, you need to assess the patient as a whole to tackle this kind of presentation. And doubling the dose of patient to whom if your PPI is not going to maintain. As I told you in this picture, you can identify your intragastric pH. So once you're going for your daily or double dose PPI, all those things you need to prominently maintain your pH should be more than 4. That's a target. And this is what for the nocturnal acid breakthrough, this slide has been mentioning about that. So if you're going to add your H2 blockers, the potential nocturnal acid breakthrough is going to come down. And nowadays, anti-reflexive surgery is not having much of potential role for that, because your fundoplication, see, I've seen many patients who are going for either Nissans or Chupe or fundoplication for your itis and other presentation. Most of the time, the patient will have persistence of reflex. Few months before, I have seen a patient who underwent surgery, and after that, the patient may have a temporary reduction of symptom, but again, within a span of time, the refluxate will be more common, because as a counsel, as I told, this refluxate is not only based upon your itis and other problem, always based upon your CNS trigger, functional hypersensitivity, reflex heartburn, all those pointers you need to recognize. That is why anti-reflexive surgery is still, even though it's having a potential role, it's not like much of interest even to the field of surgical gastro. And endoscopy, now endoscopic intervention has gone high. For example, your radiofrequency ablation, your strata procedure, sometimes in your tract which is going to inject that. Apart from, there are many other transoral incisionless fundoplication procedure. So many endoscopic interventions are there that's out of bounds as of now. So the basic things, what is the unmet need of your PPI? You need to give high dose regimen, and it may take at least 3 to 5 days to inhibit most of the acid pump. Even though if you are going to treat the patient with high dose regimen, the refluxate is not going to get completely controlled. Apart from that, it is always meal dependent. So you need to take your PPI not along with before your meals, but your potassium competitive acid blocker. There are two major things. One, the major differentiating points with your PPA and PCAMs, few things you should remember before we are going to wind up the session. One, PPA will require a prodrug, but your vonoprazan, which your PCAMs doesn't require a prodrug. And it is going to irreversibly inhibit your hydrogen potassium ATPase. And your PCAMs, it's reversibly, it is going to block. And covalently, it is going to get bind. Apart from meal dependent and meal independent. whether always capsulated needed for your PPI, but in vonoprazan there is no such guidelines. Apart from that, the short onset, within 1 to 2 hours you can able to maintain the concentration high to improve a gastric pH high. Apart from that, the steady state plasma concentration will be well maintained with your vonoprazan. And the long acting duration, which will be around 9 to 12 hours of duration for your vonoprazan, when compared to your PPI, will not be having a very long potential action duration. So this is what the short plasma half-life will be more common with your PPI, will not be there with your vonoprazan, will be on a longer half-life. So these are all the basic differentiating points you should remember about your PPI when compared to this new molecule, what is called as PCAB. It is going to act on your potassium ATPase pump in order to inhibit the activity, but it is going to reversibly bind, and it doesn't require a acidic medium, no major things, and no major requirement of any active pumps. Even the pumps, acidic pumps, if it is tends to be inactive, your PCABs will act well. That's what is very, very important. So I think I have brushed up the basic things, and apart from, there are so many indications for your PCABs to consider why it is slightly remains now superior, but I will not say PCABs alone considered to be superior, because it's very new add-on to the field of gastroenterology. For the past 6 months we have been, 3 to 4 months or 6 months we are using this PCABs for patient, almost around 150 to 200 patients I think we have been tried, but the response is almost in par with your PPI. That is one take-home message you should not forget. And the mucosal healing rate when compared to your PPIs will be having a potential response, no doubt about that. But the problem is the significant acid suppression. See, any molecule, always in a field, we should not talk only on benefits. We should talk on merits as well as demerits too. So the problem is it will be having 3-10 times more potent acid suppression. So what is the problem is, if you are going to give a persistent long duration, as the pH, if it is persisting in the higher range, that might be having evidence of hypochlorhydria, which may predispose to any events and infections, but we need papers to present. See, why this PCAB? Right now from 2024 we have been reporting, but from 2015 onward this molecule been well established in Japan. Apart from US FDA approved this molecule from 2019 to 2021. So you can use this molecule in US FDA approval. Apart from India, as of now from 2024 only they have been considering this molecule. So why Japanese population having more number of studies in this thing, potassium competitive acid blocker, mean those areas are having, and Japanese are the best in interventions, because they'll be having more of gastric adeno-CAs and other major problems being reported. And nowadays, in the early phase of adeno-CA, they will be doing a procedure what is called as endoscopic submucosal dissection. And PPI has shown, your PCABs has shown a very potential role to prevent your ulcer healing rate will be very prominent when you're going to use your potassium competitive acid blocker in the case of your ESD procedure. That is why the Japanese people are more interested to identify this molecule, and they're doing much of researches. And they are being used for a longer duration. The adverse events being documented, what is happening for your PPI as well as your PCABs almost in par, but the potential benefits is definitely well documented. And the cardiovascular interaction, even though not much of papers to document, the renal events are there, the interstitial nephritis and other problems are there to document, even with your PCABs as well as your PPI. And the adverse events as of now will be in par with your PCABs and PPI. Apart from that, the potential benefits is slightly in the higher side. That's why PCAB, for example, erosive esophagitis just for 14 days if you are going to initiate for a period of around 8 weeks of maintenance therapy at a rate of around 2 dosage regimens. One is 10 milligrams and 20 milligrams. 10 milligrams if you are going to put the patient on for a duration of 6 months, the erosions will be well documented, controlled. Around 90% documentation is there with your PPI. That is very important. H. pylori eradication very well documented with your PCABs. For around 80 to 90% of the patients will be well responded to your PPI. With your PCABs, just for 7 days of therapy, If you're going to use your amox, high-dose amox in the background of your clarithromycin with your vonoprazole, so what is the been recommending? Just 7 days we'll be having a H. pylori eradication almost around 90% in par with your 14 days therapy of your esomeprazole and other molecules. So these are all the potential events to document, and as I discussed, we need more and more papers to document all those things. Vonoprazole is definitely very well recognized, and your gastric ulcers, your duodenal ulcers, your mucosal bleeding rate, reflex esophagitis, and all those things. So your vonoprazole, even for eosinophilic esophagitis, some papers are there to document the benefit, and more studies is happening with your PPI as well as your vonoprazole. And I don't want to take much of your time. So before concluding, what I would like to say, GERD, no single molecule been significantly proven to have a major beneficial role to identify a potential target to treat. Apart from that, diet and lifestyle plays a major role, but diet and lifestyle alone doesn't show a significant potential benefit. Take home message number 2. Apart from PPIs, well documented, but be cautious when you're going to use your PPI based upon the clinical parameters, how you're going to recognize and how you're going to tackle. And PCABs, well maintained for a short duration of therapy, acute onset of symptoms, you can use your PCABs very well, and depending upon to what indications you are going to target, as I told you, the assessment of your patient is very important to target your PCABs. And apart from adverse events, be very cautious to document, and interactions. So your vonoprazole with your cardiac molecules, being as of now no major events, and there is no major trials to combine your vonoprazole with your prokinetics as of now, and we need more papers to document that. So prokinetics with your PCAB, still no major documentations. Apart from that, other coexisting molecules like your sucralfate, your rapamycin, all those things still need more papers to document. But in the acute phase, major symptoms, PCAB will be having a potential role to consider. With this, I'm happy to rest my presentation. Thank you all for patient listening. Any questions that you want to
So how frequently they are encountered?
So, sir, we will take the questionnaire separately. So, thank you, Dr.